Sorry for that. I was muted for some reason. Here. Can you see my screen? Not yet.
Not yet. There we go.
Okay.
Hey, good morning, everybody. Thanks for that, and thank you for joining us in another Q&A of Seattle Science Foundation and the Swedish Neurosciences Institute. I'm Matthias Costa, one of the cerebrovascular fellows here at Swedish. I want to thank Dr. Cameron McDowell for helping with this series the last 2 years already. Today we have the pleasure of having with us again Dr. Santiago Ortega. Here he's MD at the University of Alcalá in Madrid, Spain, and did his internal medicine and neurology residency at Medical College of Wisconsin in the US. He then completed a neurocritical care and stroke fellowship at Columbia University and an endovascular neurosurgery fellowship at Mount Sinai in New York. He's currently the director of neurointerventional surgery in neurology at the University of Iowa, the Neuroendovascular Surgical and Neuroradiology Fellowship Director there. He's also the Vice Chair of the Mechanical Thrombectomy 2020 Plus Initiative and Treasurer of the SVIN, Society of Vascular and Interventional Neurology. He's Director of the Cerebrovascular Neurointerventional Lab at the University of Iowa, and his research interests include cerebrovascular autoregulation and hemodynamics neuroimaging as a selection tool, and developing novel endovascular approaches and devices to treat cerebrovascular ischemic and hemorrhagic disease. Currently, he is author of more than 130 publications in peer-reviewed journals, as well as industry and several investigator-initiated studies, including an NIH Aero 1 funding. Thank you so much, Dr. Santiago, for being with us. It's a pleasure to have you as usual, and I'm going to stop sharing my screen.
Thank you. Thank you for such a kind introduction. We have to make it shorter next time. You make me blush a little bit with so many, titles there. But thank you. Thank you for having me back. And after such a great experience. And today I was in charge to prepare a talk about endovascular therapy for acute ischemic stroke. And it was really great for me to go back and update my talks, which were like 2 years old, because I realized how much more we have done over the last 2 years. In 2015, probably this was like I could do this talk in 5 minutes, and now it's just been like crazy how much things are evolving. And I kind of decided to go through the key features. These are my disclosures. The only pertinent thing is some of the studies I'm going to talk about. I was also part of the steering committee and some of the design and institutional PI, but the rest is not relevant. And the talk for today, I kind of divided in a few sections. First, the efficacy of endovascular therapy for LVO, where we're going to review a little bit of how we got here, the 2015 initial trials, even the ones that were negative in 2012. We're going to talk about the late window trials, including the newest ones from this year. And then something very exciting, which is the expansion of LVO. We know this year we had a lot of papers coming up in large core, which is a big deal for all of us about new protocols, new ways to kind of triage these patients, and also how are we going to organize our systems, and the kind of some of the new frontiers in DIVOS and MIVOS as the technology gets better and we can go farther in the into these vessels to chase clots. And then I'm going to finish with a little bit of some of my research in R01 research, which is systems of care, and a little bit of the trials also in IV thrombolysis, just a summary of what is out there, including some tenecteplase. Then hopefully this will occupy the next 45, 50 minutes, and then we can have some discussion. In regards to the evidence, I know this audience probably knows very well what happened, but just as a brief summary, we realized very soon that our TPA was not working in large vessel occlusions, and the rates of reperfusion and recanalization on those areas when they presented with acute symptoms was quite low in terms of 5% in the distal ICA and even less than that in the basilar regions. Because of that, we realized that, or at that time, people realized that we needed something different. And we can maybe say that PROACT 2 was the first well-designed randomized trial. It was a phase 2 trial, international multi-center open labeled, in which 180 patients presented with acute symptoms within the first 6 hours were selected based on angiographic assistance of LVO and were randomized 1 to 2 to heparin alone, which at that time was the standard of care, versus heparin plus urokinase, IA urokinase. Basically, the catheter was left there, and 9 milligrams of IA urokinase was given. And this trial actually resulted for the first time in a positive trial that showed that we decreased the disability by treating patients with LVO in anterior circulation. And we, at that time, with this therapy, 66% of the time, the vessel can be open. The price to pay is, with this medication, 10% risk of a symptomatic ICH in comparison with heparin alone, but that didn't seem to affect the primary outcome, which in this case was disability at 3 months. And the mortality rates were very similar. Because of these initial results, the industry started to get excited about our field. And 2 main registries started at that time, the MERCY trial and the MERCY multi-MERCY trial. It was a single arm kind of a registry on patients who didn't qualify for IVTPA at that time, up to 8 hours. It was multi-center international. And this the MERCY device, which some of you remember, I used it twice, I think during my residency. I didn't use it during my fellowship. It was already obsolete at that time, but basically demonstrated that also with mechanical thrombectomy, about 60% of the time, 69 in the multi-MERCY, vessels can be open. And when you open the vessel, even though this registry didn't really look into so much imaging, but when you open the vessel, you tend to have better outcomes. And this is the first time recanalization was considered as the main predictor of outcome. As a result of this, basically the 3 trials were started using this technology, and were published all in 2012. If you guys remember, I was looking for a job at that time, finishing my fellowship, and nobody wanted to hire an interventional neurologist after these trials were published because endovascular therapy didn't seem to be very promising. The IMS3 was a trial in which the target was 900 patients, and we were going to randomize patients to IVTPA versus IVTPA plus endovascular in the anterior and posterior circulation. It was stopped after the second interanalysis because it crossed the futility boundaries. And the synthesis trial was primarily in Italy, 362 centers. In the early window, randomized to endovascular versus IVTPA. There was no IVTPA in the endovascular arm. And MR Rescue tried to kind of test the concept of a penumbra, using penumbra by CT, P, and MRI, initially MRI, and then they switched to CTP, and really evaluate if opening vessels in patients with a penumbra pattern could benefit at all. Unfortunately, these 3 trials were negative. IMS3 and synthesis showed, as you can see here, no difference in the primary outcome, which was MRS at 3 months, and the rates were very similar to IVTPA. And then MR Rescue, the design, as I mentioned, was a little bit complex. The number of patients, as you can see, in the penumbra pattern, non-penumbra pattern that were treated and non-treated with endovascular therapy was quite low and did not show any signal whatsoever. And that was kind of bad, but thankfully we learned some lessons from this that was utilized in the second generation trials subsequently. Number one, that definitely it was observed that almost half of the patients in IMS3 did not have a clear diagnosis of LVO with a CT angiogram before they went to the angio suite. And when they went to the angio suite, 18% did not have a clot. As you can imagine, this affects drastically the design of the trial because the trial has to be analyzed with intention to treat analysis. And in this discrepancy or inability to see LVO cannot really affect the outcome, the primary outcome of the trial. Also, there was a heterogeneity, a mix of anterior and posterior circulation in IMS3, which we know nowadays that this is a very different disease with different natural history. And most importantly, with these trials, we learned what really reperfusion needs to be, because what they considered in this trial reperfusion was actually TK2A. And nowadays, we will never really stop in a TK2A because we know that's not associated with better outcome. But the majority of patients that underwent endovascular therapy in these trials only had a TK2A, and the percentage of TK2B was less than 50%. And finally, they were quite slow in the process. People and hospitals were not used to mechanical thrombectomy. Therefore, the systems were not prepared to really expedite the treatment of these patients. Fortunately, two lines of research occur after this. Number one, from the industry perspective, they realized that the first generation stent retrievers was not good enough, and they came up with the second generation devices, which are some of them still in place and we are very familiar with. And they started these single arms registries that demonstrated that with the second generation, you can open the vessel much more efficiently, up to 90%, which is pretty much what we get right now, even though we have newer generations, but really the rates oscillate between 80 to 90%, and with very little chance of really damaging the vessel by doing that. And at the same time, during this time, the large bore catheters also started to be developed, and the aspiration technique also started to become popular. From this time, which I didn't know until I prepared this talk, there were two randomized trials, device trials. The first one was the SWIFT, which was the scientific premise for SWIFT prime later on, in which basically Mercy was compared with Solitaire in patients who presented less than 8 hours. And here it was a non-inferiority trial to really evaluate primarily what at that time was TIMI, not TIKI, more than 2 without ICH after 3 passes. And Solitaire was superior, or was not inferior than Mercy. And then the other one was Trivo 2, which was kind of a similar design, but this was open label randomized, which was randomized by stratas of age, and patients were randomized, and they realized that Trivo opened the vessel better up to 86% of the time without any concerns of symptomatic ICH. In fact, less rates of symptomatic ICH. The other line of research, in addition to the industry improvements, was the better selection for patients, which, as I mentioned, it was really a bad quality in the initial trials. And the concept of mismatch for this pivotal 2015 trials was very important. 3 main imaging modalities. One was aspect, which nowadays is a very frequent tool for all of us, in which is a semi-quantitative scale, 0 to 10. 10 is you don't have any hypodensity, 0 you have a complete hypodensity and effacement of one hemisphere. The worse the scale, the more is infarct you have already established. Also, the concept of multimodal or multi-phase CTA to really evaluate collateral flow and kind of really distinguish the good and bad reperfused tissue was developed. And of course, the CTP MRI was improved, not to just to the qualitative aspects, but also to the quantitative aspect, to the point that we know nowadays. We have now more softwares that can provide this information. At that time, there was only one, and it was allowed us in CTP and MRI to really evaluate infarct volume, or estimate infarct volume, I should say, because CVF doesn't really quantify it, just estimates. And then the most important, the hypoperfusion. Based on those 2 patterns, you can decide if your tissue is at risk and it still has a chance of salvageable tissue if reperfusion occurs. And this is in a quantitative manner, which was very, very helpful. Then implementing these 2 lines of research, getting better selection tools with the 3 modalities I mentioned, better stent retrievers, as well as becoming faster. The initial 5 trials, 3 came afterwards, were published in 2015 in New England Journal of Medicine. And just to summarize them all, because you guys are very familiar, basically all of them really kind of enroll adult patients with different types of disability. Mr. Clean was the most inclusive, NIH only 2 or more, and also up to majority 6 to 8 hours, except for ESCAPE that went up to 12 hours with the multi-phase CT. And patients were randomized in all these trials in a standard of care, including TPA, if patient was within the window, versus a standard of care plus endovascular, which in the majority of the studies was performed with a stent reaver at that time. And all these trials now had a measurement of LVO, yes or no, by a CTA or MRA, as well as a measure of infarct minimum with an aspect, and some of them advanced imaging with CT perfusion or multi-phase CTA. It's important to say that all these patients, all these trials enroll patients with at least aspects 6 to 10. Therefore, the infarct was not extensive. And in all these trials, it demonstrated that there was a substantial benefit in decreasing disability at 3 months, as well as good reperfusion rates without compromising hemorrhage or increasing death in comparison with the standard of care. Then as a result of these trials, we heard that first they were meta-analyzed in a patient-level meta-analysis with Hermes, demonstrated that they doubled the independence at 3 months for these patients. The number needed to treat was 2.6, and therefore, and as I said, with high rates of early recovery, low rates of disability, and not increased rates of mortality, symptomatic or parenchymal hematoma compared with the standard of care. Therefore, in 2015, the guidelines were published, and for the first time, endovascular therapy, which was a big moment for our field, became a standard of care. And I want to mention, for those of you who know, I have a big interest in global primarily in a stroke and hemorrhagic disease. And another trial that I think is important to mention that came 2 years later is Resilient, because this is an endovascular therapy very similar designed to Mr. Clean, very inclusive, using CT and CTA within 8 hours for LVO anterior circulation, randomized to a standard of care versus a standard of care plus endovascular therapy, but done in a low middle income country. And the results were exactly the same as we were seeing in the results of the initial 2015 pivotal trials, which means that mechanical thrombectomy, even in a region of the world that doesn't have the most sophisticated rehabilitation, the most sophisticated neuro ICU, it still has a dramatic improvement in patients when it's given with the same kind of selection criteria as we use in our standard guidelines. And this is important because even though we think mechanical thrombectomy is well expanded nowadays in our society, if you go outside US, Europe, Australia, and EVT, endovascular therapy, works in also low and middle income countries the same way it works in more developed countries. Let's go to the late window trial. This is more recent. This is 2018. After we started to do mechanical thrombectomy in the early window, we realized that there was still a cohort of patients that presented after, of course, were really extended after a few hours, but a lot of percentage came 6, 8, 10, 12 hours, and the aspect was small. Then that percentage of patients probably could still benefit from endovascular therapy if given, but again, it was not in the guidelines. That was the scientific premise for 2 trials, the Dawn trial and the Diffuse trial, which basically tested the same hypothesis as the pivotal trial selection criteria, and with the window expanded from 6 to 16 in Diffuse and 6 to 24 in Dawn. The Dawn trial was a multi-center prospective. This is when I also think that this adaptive enrichment design that now is part of a single trial that is designed in endovascular therapy started to be kind of more prominent. And these 2 trials use Bayesian adaptive enrichment that has some advantages in the design to change a little bit the criteria based on the results of some of the analysis that is performed, interim analysis that are performed. And the Dawn trial evaluated this the endovascular therapy using Trevo device 6 to 24 hours compared with the standard of care, and got for selecting the patients, got what we call the mismatch, the clinical mismatch, which they define as a mismatch based on age, NIH. Results were very dramatic, a very similar range as the pivotal trials, doubling the number of patients who achieve independence at 3 months without increased risk of hemorrhage and without increasing any risk of death compared with the control. This trial was a little bit more simple criteria that were primarily used on imaging mismatch. The clinical mismatch was not taken into consideration. Selected if there was a mismatch with a mismatch ratio more than 1.5 and more than 15 mLs. And basically, patients were randomized to endovascular versus control. It went up to 16 hours, as I mentioned. They had to have also the evidence of LVO on a CTA, and results were very similar, almost actually better than the pivotal trials, because patients in the standard of care arm had worse outcomes than in the initial 6-hour trial, and probably is because the majority of these patients did not get TPA since they presented in the late window. But the effect of endovascular therapy was quite similar, achieving almost half of the patients independence at 3 months, getting a good recanalization up to almost 80% with very little risk of ICH and death. Then this is what I just mentioned. The effect size was very similar between early and late window. Obviously, we have to remember that the selection criteria were different. Dawn and diffuse uses the clinical and radiographic mismatch using advanced imaging, and but the effect is the same. And as a result, the guidelines were updated in 2018. And obviously a meta-analysis of these trials, plus some of the patients that were enrolled in also REVASCAT, and the patients who were enrolled in ESCAPE after 6 hours were also included in this meta-analysis. And this meta-analysis basically showed that the effect, as the trials showed, is quite increased. But more importantly, and I think this is really interesting, that patients, when they when we did actually a dichotomization 6 to 12 versus 12 to 24, the effect of mechanical thrombectomy is actually stronger in the patients that presented 12 to 24, and probably because those patients for sure have, in order to present with low infarct volumes and qualify for the studies, they have tremendous collaterals. Whereas in the 6 to 12 hours, we still have some patients with intermediate collaterals at larger volumes at the time of presentation. But as I mentioned, this kind of is what we are now all do. These are the guidelines update in 2018, and basically now we can go up to 24 hours, and we have a very clear distinction in terms of the physiology of these patients. And we know nowadays that approximately 45 patients of our patient population, depending where you practice, are going to be fast progressors with small collaterals, and about 55% are going to be probably slow progressors, and we'll be able to treat them using the criteria that I aforementioned with endovascular therapy up to 24 hours. And then last year, one more study was presented, which is Mr. Clean Late. We challenged the concept of requiring advanced imaging for selecting patients in the late window. This is from the group from Netherlands. They have a great infrastructure with over 50, 60 centers working together, putting a lot of papers. And in this trial specifically, the objective was to assess the efficacy and safety of endovascular therapy in patients in the late window, but using only selection with CT and CTA, no advanced imaging. About 535 patients were selected for the trial and randomized 1-to-1. And the trial showed that when you select these patients with CT and CTA alone, there is still a significant benefit to improve outcomes for endovascular therapy. And also, even though you always have are concerned about less imaging, maybe higher rate of complications, although there was a little bit higher rates, it still was very similar, or no, was not out of proportion from what we had in the initial pivotal trials. Therefore, is not considered out of range, 7% symptomatic ICH after endovascular therapy, and the mortality was very similar between both groups. Therefore, I think it's not in the guidelines, but we soon are going maybe to start to see a shift in this concept. Also this year, finally, even though it was attempted several years ago, we had some strong evidence that probably will get into the guidelines very soon about posterior circulation LVO. I have to say that the initial experience was not that great. The basic trial several years ago really compared efficacy and safety of endovascular therapy within 6 hours for basilar occlusions, randomized 1-to-1. However, this trial, as you probably heard, had some design issues. Number one, the enrollment was quite slow. Because of that, they had to change the inclusion criteria to be less strict and open the door to older patients as well as patients with low NIH. And there were some important concerns about crossover, with over 30% of the population crossing from the medical arm to the endovascular arm. Because of that, these results were not taken in a very strict way, or they were not considered like high quality results. But nevertheless, the trial ended up being negative. There was no differences in this patient population when they receive endovascular therapy, even though we know they are the sickest of all LVOs, the basilar occlusions. And there was no differences in MRS as a sheath analysis, MRS as a 0 to 2, or early recovery at 24 hours, and the mortality and the symptomatic ICH rates were very similar. After basic, we had BEST, and BEST, again, another trial from China in vertebral basilar occlusion, less than 8 hours. Some concerns also about some crossover. Patients were selected based on the evidence of LVO, as well as lack of cerebral mass effect, hydrocephalus, or extensive ischemic changes on the brainstem and cerebellum. And the trial was terminated early with no significant differences in between the groups in disability, mortality, or ICH because of high crossover population because this trial was performed after the pivotal trials in 2015 and the guidelines started. Most of the family members really didn't want their family to the patient to kind of really undergo a medical therapy, and were crossover into the EVT arm. Therefore, again, not a very successful trial. But this year we finally got two well-designed, well-done posterior circulation trials, Baoshi and Attention. Baoshi had the objective of efficacy and safety of endovascular therapy with medical therapy versus medical therapy alone in patients with basilar occlusions from 6 to 24 hours. And in those basilar occlusions were actually selected by CT or MR, and had to have an NIH more than 10 in order to get enrollment. The randomization occurred 1-to-1, and this time was terminated, but not because of futility or bad crossover, but because of because reached the significant threshold at the second or first interim analysis. And it showed actually that patients, in this case, the MRS was 0 to 3, not 0 to 2, because this disease has a worse natural history, but showed also that the number of patients in that range category 0 to 3 was double compared with controls, with endovascular therapy was provided within 6 to 24 hours in this patient population. We have to also remember that this population was primarily Asian population, and the number of ICAT is quite high. Therefore, in this trial, which might not completely apply to the Western countries, the patients had actually 55 intracranial stenting or angioplasty performed in these patients. Great news for posterior circulation, and this was published at the same time by another group in China. This time, this trial has the difference that is not only basilar occlusions, but also distal vertebral occlusions, and instead of going to 24 hours, went to 12 hours. They used the concept of PC aspect too, similar to Baoshi, in which They estimated with the posterior circulation aspect the hypodensities, and they had to be more than 6. And it was performed in patients when the NIH was more equal or more than 10. They had a higher number of enrollment, 342, randomized 2-to-1 to endovascular therapy, and results were very similar, doubling the number of patients achieving independence at 3 months, and MRS 0 to 3. And there was also, in this case, decrease of death compared with controls in this population without an increase in symptomatic ICH. Therefore, I probably expect that this is going to be included in the guidelines very soon, although most of us already kind of practice this in their clinical routine protocols. Let's talk now about something more exciting, which is the expanded of EVT. A lot of things have occurred since this February at the ISC, and then also we heard from the European Stroke Conference 2 weeks ago about the large core. The concept of large core came about after we started to do a lot of thrombectomy when the guidelines were published, and it was noticed that in some retrospective multi-center collaborations, there was still a beneficial effects, even if the aspects were 5 or 4. And, when you go to 2 to 3, maybe it's not that clear. And then definitely the 0 to 1 aspects, which means all the infarcted territory, there was actually no patient that achieved a good MRS at 3 months, and also had a higher rate of hemorrhages. In the Hermes, primarily from patients from Mr. Clean, there was also about 110 patients that were having aspect less than 6 included in the meta-analysis, and therefore, after looking into differences, it was observed a signal, and that signal was primarily in the aspect 3 to 5. This was the scientific premise to kind of build the 4 trials that were published this year, and or at least presented. And basically, this is a summary of this. Rescue Japan was presented last year. It was primarily an MR based large cohort trial that randomized patients 1-to-1 to endovascular and versus EVT. And as we know, it was showing positive results for endovascular therapy in primarily Japanese population. In ISC in February, we got Angels Aspect and Select 2. Angels Aspect is primarily a CT-based with some MR2 large core trial, a little bit higher sample size, 230 and 225 in the medical group, and also showed positive results in the anterior circulation when patients were treated with endovascular therapy. And Select 2 was a CT and a CTP base. CTP was also used as inclusion criteria, and with a slightly different threshold for core. In this case, the threshold for CTP was 50 cc's to include these patients, and again, showed positive results. And last 2 weeks ago in Munich, even though this has not been published, Tesla was presented, and this actually did not reach a statistical significance for benefiting EVT, although there was a trend. And as we can see, comparing with the other trials, the sample size is right in between. And this was a primarily pragmatic CT-based trial using only aspect, and this went to 0 from 2 to 5. Unlike the other ones who use especially Select 2, 3 to 5. And just for this presentation, I prepared quickly a meta-analysis for you guys in which we quickly in the lab analyzed the results presented for these 3 trials. And I think that because there is a little bit of equipoise, especially after Tesla was presented with negative results, we kind of see that definitely for MRS 0 to 2 and 0 to 3, there's a significant benefit of EVT compared with no EVT in this population. And the majority of these trials went to up to 24 hours, okay? 0 to 24 hours. For ICH, even though Select 2 did not show any difference in ICH, the other 3 trials showed a tendency or definitely a propensity. And then in the meta-analysis, we saw that there were significant differences in symptomatic ICH. For mortality, there was no differences when we analyzed for the 4 studies, and for a hemicraniectomy, which only it was reported on these 3 trials. There was no clear difference in reducing, because one of the theories is that even though maybe the effect of EVT might be that you need less hemicraniectomy because there is less edema, but it did not pan out to be clear after analyzing these trials. And then in terms of reperfusion, there is this also concept that perhaps these patients are more expanded, they have large strokes, and perhaps the reperfusion rates are not the same. This is exactly the same reperfusion rate, between 70 to 90% reperfusion rates of TK2b or more. Then I think this is your daily protocols. Nowadays, we in Iowa treat aspects 3 to 5, but again, this has not been implemented in the guidelines. And there are 2 more trials, tension and mostly in Europe, that are still pending the results. Then we have this, I expect to see a large meta-analysis, and we get a better sense of the subgroups that might have the best outcome and benefit the most from endovascular therapy, and maybe they will discard a little bit the groups that might not benefit as much. Okay, having talked about the large core, which we are already kind of, the trials are published. I'm going to talk now about the MIVOS and DIVOS, which we still are, we have not a strong level 1 evidence, but probably in the next 2 years, we're going to see a lot of things coming up. The initial analysis from IMS3 showed that perhaps in M2 occlusions, which probably all of you guys now treat these days, there was a little bit of a benefit of endovascular therapy. Hermes also included some did a subgroup analysis of the M2s, primarily in the initial horizontal portion of the Sylvian fissure, and it showed also that there was a signal towards potential benefit of endovascular therapy. But what we've seen in the last 3 years is that technology has evolved so much that going to M3s and M4s probably is not a big deal anymore for any of us. And there is some new stent retrievers and aspiration catheters with smaller diameters and longer lengths that really allow you to consider taking care of these patients. However, there are some challenges for MIVOS, and this is all homemade. This is my personal opinion. I think the definition of MIVOS still not clear. If you look into the trials I'm going to show you in a minute, there is different definitions of what a MIVO is and the DIVO is. Also, it's important to differentiate primary versus secondary MIVOS, because as I will show you in a minute, the outcome is different. Secondary MIVOS are usually the result of LVO, and therefore they probably have a bigger infarct established at the time we are treating those, whereas primary MIVOS are the ones that really come with the clot from the first time on those regions. And we're going to see more and more secondary MIVOS as our thrombolysis improves. We've seen more and more MIVOS, I think, since the use of tenecteplase, in which the LVO might be dissolved, but only partially, and then the patient presents with a distal clot. Posterior circulation might not be the same as anterior circulation, as I said, and then also the devices are kind of, we don't know what the best technique might be. Is combined technique better? Is aspiration better? Is stent retriever better? Which one causes more subarachnoid hemorrhage, which is one of the outcomes we see when we go very distal? We don't know. And finally, these patients have lower severity at presentation. Therefore, probably MRS might not be a good outcome to measure these patients, since the disability to start with is much, much smaller, and it's not infrequent that the NIH is less than 6 in these patients. We recently did this meta-analysis of all the literature available for MIVOS, primary and secondary, and as I mentioned before, the successful reperfusion for both is similar. We can take care of this primary and secondary MIVOS, but the outcome is different, with worse outcome in the secondary MIVOS, because of course, as I mentioned, they already have a LVO before that time, and the hemorrhage rates are also higher in secondary MIVOS. The technique, as I mentioned, we don't know what to use, but it seems that perhaps the rates of reperfusion is equal in both stent retriever versus aspiration, even the combination. However, the risk of hemorrhage might be a little bit higher 6 versus 1% in all available literature for for a stent retriever, perhaps because of the disruption of the endothelium when we are so distal, which the vessel is much more fragile. And these are the ongoing trials. Hopefully within the next 2 years, we'll start to hear some results. It's important to say that all these are primary MIVOs. Distal in Switzerland, that you can see the definition for MIVOs, they are going also posterior circulation, and the inclusion criteria has to be NIH more than 4 or a clearly disabled symptoms such as aphasia or neglect. They still take MRS at 90 days, which I think is a concern, but we'll see when the time comes. In France, we have discount that they also go M3s, A3s, and P3s. NIH more or equal than 5, still MRS. Escape MIVO, which we are part of, started in Canada, and it takes primarily M2s and 3s, A2s, A3s, and P2, P3s. Again, similar criteria, NIH more than 5, or a disabling symptom if it's less than 5, that includes neglect, anopsia, or aphasia. And MRS at 3 months is still, the shift analysis is still the primary outcome. And then distals is going to be starting very soon in the US, and very similar, but here the outcome is successful reperfusion without ICH. This is an industry trial, and that's why I think they went for a different primary outcome. Then more to come in the next few years. Let's talk a little bit about low NIH. As I mentioned, low NIH is also another frontier. All the trials except for Mr. Clean did not include NIH patients with NIH less than 6. Therefore, we don't, neither in the late window trials. Therefore, we don't know what the effect might be when you have a patient with LVO and also NIH less than 6, especially in young patients with a lot of collaterals. Some signals from Hermes subgroup suggest that maybe the effect of endovascular therapy is not as great, and when the NIH is more than 10, based on the subgroup meta-analysis, as well as in reduction of mortality. And that's not surprising because these patients probably are not going to die as frequently. This is a summary. It's a nice paper that summarizes all the available literature on low NIH and non-randomized studies. That was the premise for the 2 trials that I'm going to talk about in a second. And they was all over the place. There's definitely equipoise in some of these registries or collaborations. Endovascular therapy was superior for disability rates at MRS less than 2 compared with medical therapy. In some of them wasn't. In some of them it showed higher rates of hemorrhage. In some of them didn't, in the symptomatic and asymptomatic ICH. And the same for the shift analysis. Some of them, the shift for NIH, which means delta NIH between admission and discharge, some of them showed a significant difference, some of them did not show a significant difference. Then as a result of this was the perfect scenario for a clinical trial. And even before I get into it, a new concept came up from this collaboration of low NIH LVOs, in which in the early window, in which the concept of endovascular therapy also switched a little bit and was incorporated in one of the trials. Because we tend to see these patients, and when they come with a very low NIH, we wait for them, right? And if we wait for them, we expect that they're gonna maybe recover, or they are gonna just deteriorate, and therefore we have a better justification when they cross the threshold of more than 5 or 6 for NIH stroke scale to treat them. But what this study showed is that if you treat them immediately with endovascular therapy when they come with low NIH and an LVO, patients do relatively well. If you just do medical therapy, they don't do that bad either. But if you wait until they worsen, the patients did worse than even the medical therapy. Again, this is all is a matched multi-center analysis and is retrospective data, but that concept actually was incorporated in one of the trials, the MOSTI trial, which is primarily European sites, that they are randomizing patients with LVO and low NIH within 24 hours. And when they randomize to best medical therapy or rescue mechanical thrombectomy, it means they don't treat them from the beginning, and they actually allow them to get the medical therapy or deteriorate and treat them versus initial treatment. And the MRS at 90 days is the primary outcome. And the one we have in the US, which right now is on hold, is the endolo, which also goes up to 24 hours and includes patients with LVO, including M2s. And when it goes beyond 8 hours, then it needs the inclusion criteria needs a perfusion mismatch more than 30. These are ongoing trials, and hopefully we'll know the results very soon. And then just to finalize, let me see, I have 5 more minutes to go. We have, I want to share with you some of the evidence for IV TPA when patients come to comprehensive stroke centers and they are shown to have an LVO. There are 6 trials that we saw 2 years ago being published in New England Journal of Medicine. I'm not going to go into details. Those were all trials in which they compare TPA plus endovascular therapy when the patient comes to a thrombectomy ready or thrombectomy capable center or a comprehensive center versus only thrombectomy. You don't need to do a TPA. It were from China, Europe, North America, and Japan. The majority were not inferiority, except for Mr. Clean IV, which was superiority, and all of them show that there were no differences. Then you can choose to give it or not give it, but there was no direct endovascular therapy without thrombolytics with TPA. In this case, IV TPA was not inferior. And then this is a meta-analysis presented last year at the World Stroke Conference with all these trials and showed exactly the same thing. Basically, that direct to endovascular therapy when you go to a comprehensive stroke center is not inferior to just intraarterial TPA. Again, this is only for patients that come to your center directly. This is not for transfer patients. For transfer patients, this does not apply. There was a little bit higher chance of reperfusion hemorrhage, but did not affect the outcomes. And if the patient comes in that very early window, based on a subgroup analysis of this patient-level meta-analysis of 2,400 patients, perhaps giving TPA might make sense, especially in that golden window, because there were higher rates of reperfusion with only thrombolysis. For tenecteplase, which has become very popular since our colleagues from Australia published STEN-IA, this is the premise for using tenecteplase in patients within 4.5 hours. These 3 studies really comparing tenecteplase versus TPA, and it really showed, which I summarize in this meta-analysis, that tenecteplase seems to be better than alteplase for opening the vessel before the patient got into endovascular therapy. There were more spontaneous reperfusion, or not spontaneous. There was a more reperfusion or recanalization to IV thrombolytics using tenecteplase than alteplase. There were better outcomes in the patients who received that, and these are all large vessel occlusions. And there was also improvement of the shift. And STEN-IA showed that the dose for tenecteplase doesn't need to be the 0.40 milligrams per kilogram. The 0.25 is equally effective and actually has not additional benefit to have a higher dose, and the rates of hemorrhage and can be lower. However, 2 weeks ago, and this is not published yet, we heard that the application of tenecteplase from 4.5 hours to 24 hours by Timeless did not seem to have that effect. And we have to wait for the results of the trial to be published, but Timeless was announced at the European Stroke Conference, and it showed that when tenecteplase is used in the late window in patients who might qualify for the tenecteplase and thrombectomy, did not really pan out to be a positive study. And then this is just to finalize. This is what I also invest quite a bit of my time, systems of care. This is a part of our R01. We kind of really have the dilemma, right? That what is the best system of care pathway, depending if you have a suspicion for LVO and non-LVO. This is the $1 million question, because how to detect LVO in the at the scene is what is going to determine. And right now we have several scales that we know are at the best modest, 66% sensitivity, maybe 70% specificity, but we don't really can tell 100% if the patient is going to have or not an LVO. If you send a non-LVO to a comprehensive stroke center, you don't do a service to that patient and you might delay thrombolytics. Whereas if you send a patient to with an LVO to a closed center, depending on the distance between the two centers, you might actually delay endovascular therapy, which is the most effective. For trying to answer this, RACE-CAT was this a multi-center cluster randomization trial performed in Barcelona, in entire Catalonia, not only Barcelona, in entire Catalonia. And this trial was trying to kind of select patients based on a RACE score more than equal or more than 5, and randomized to go to the drip and shift paradigm versus direct to the comprehensive stroke, the motherhood paradigm. Patients were randomized at the scene by the paramedics with the support of physicians on the phone. And the trial ended up showing that the scale, the RACE score, that is used by paramedics can predict LVOs with a certainty of 71, 76%, that there is still a lot of mimics that were not picked up, such as hemorrhage, about 10%, and also ischemic TIAs and mimics. And the trial ended up showing that there was no benefit going one way to the other. Then neither or was better than the other. Going to the local stroke center versus the thrombectomy center in the patient with the only ischemic did not show any benefit. For the mimics, neither. However, something very interesting that we are going to probably start to see as the ICH trials start to show that time is important and maybe drainage of the hemorrhage is important. Patients who were transferred to the thrombectomy capable centers actually had worse outcomes than if they went to a local center. And this is probably attributed to deterioration during transfer and intubation. We need to kind of hear more about this. I think they're publishing a subgroup analysis on this, but this is something very important as we kind of decide how to triage ICH in our population. And then the other systems of care important trials are occurring are the direct to angio. This is based on the premise. This is a meta-analysis also we did publish few months ago, in which people are considering for patients that come from transfers or from direct to the ED, taking those patients directly to angio and perform a Dyna CT or a CT with the other assistance, the Philips CT, to rule out hemorrhage. If the NIH stroke scale is more than 10, because the likelihood of having an LVO is quite high, and that invariably decreases the time to reperfusion about 30 to 40 minutes. And therefore, there was a signal to better outcomes in all these retrospective collaborations of better MRS without compromising the risk of having increased ICH. As a result of that, there was one trial, single-arm trial, also from the group from Barcelona, called it's direct to angio. Is the direct, it's not direct, I forgot the name, but basically this trial kind of randomized patients direct to angio suite versus going to the CT in the ER and getting CTA protocol. And it was about 70 patients, one-to-one randomization. MRS shift analysis was the primary outcome, and it showed that there was a benefit towards direct to angio in this patient population. The majority of these patients were transfers, but there were some of them that went also directly to the ED center in the comprehensive stroke center. And most importantly, by doing a Dyna CT, you are saved, and they did not show an increased rate of symptomatic hemorrhage. You could estimate really well that the patients didn't have an extensive infarct, and there was not increased rates of hemicraniectomy or mortality. And more to come. I think there are 2 trials now testing this hypothesis in a multi-center fashion, and we'll see what the results are. And this is something that I want to end with, which is a concept we probably, I don't have time to go through all the neuroprotection trials that are happening right now. We know that there was one concluded, the ESCAPE NA, but this trial really brought my attention, which is something that we are going to see more and more. The additional treatments after or before thrombectomy. And in this case, what they did is they did a single center randomized trial in which they actually treat patients with endovascular therapy. It's called the CHOICE trial. And after the patient achieved recanalization and reperfusion to TK2B or more, they administered intraarterially TPA. And basically, you open the vessel, we would say, okay, the job is done. They still did that. They gave thrombolytics intraarterially, and they really, because the concept of perhaps we have this microcirculation reflow phenomenon in which we see that some patients, despite optimal reperfusion, they still don't do well, or they don't recover fast. And they actually showed that the risk of hemorrhage when you give in a complete reperfused patient TPA did not increase. And these patients had a trend. Again, this is only a phase 2 A/B trial, but there was a trend towards better outcomes in patients with TPA given after reperfusion. But the primary outcome, which was safety, did show not increase in death or symptomatic ICH, which I think this is very promising, and we're going to see this more to come. Again, thank you for your time. Sorry I extended a little bit more than last time. And I'll be happy to maybe, I think there's so many things coming up that I couldn't really summarize more because it was too much for only 1 hour. But I appreciate the opportunity to share with you, and happy to maybe discuss or talk about anything that you might feel it might be beneficial. Thank you.
Amazing. Thank you so much, Dr. Ortega. It was an amazing talk, very comprehensive. Dr. McDougall, do you want to start with any comments or questions before I?
Yeah, thanks for a great talk that really highlights just the explosion of things, starting so modestly and so slowly, back with PROACT 2 and just the explosion now, how difficult it is to keep up. It's very exciting and almost intimidating, the amount of data now we have to synthesize in making decisions, and it's really few patients that aren't going to be eligible for some sort of endovascular therapy. You start looking at the low aspect patients in the large core. It's very interesting stuff. I want to just go to ask a specific question though about the posterior circulation, because I think that it's so intuitive to us now that restoring flow is essential and obviously a good thing. And the thing that I think we were all a little bit slow to grasp onto was just how low the risk of hemorrhage is with reperfusion. It was always a very frightening thing, and I think it really slowed down a lot of progress that we were afraid to revascularize, people with significant cores, because we just assumed that the hemorrhage rate was going to skyrocket, which really hasn't been the case. But when you look at the posterior circulation, you have 50, almost half of those patients ending up getting angioplasty and stenting.
It was almost 50%, 44% of patients in the Bauchi treatment probably got angioplasty or stenting. It's also because of the ICAT, underlying ICAT in the Asian population.
Right, they're Asian.
Well, it's not just in the Asian population. When you move into the posterior circulation, I mean, that's what we see much more frequently. It's not an embolus, it's ICAT, and so you're faced with that dilemma pretty frequently when you go into the posterior circulation. And I'm wondering if there was anything on that, or what your thoughts are on the use of antiplatelet drugs, because I find that it's very hard to keep those ICAT lesions patent if you're not using antiplatelet medications, and then that's a whole other can of worms. And it's the same thing with the patients who come with excellent collaterals and deteriorate in delayed fashion. They're more often ICAT, and so the treatments are more are a higher risk treatment, and you have this antiplatelet dilemma. And I just wondered if you could talk a little bit about that.
Yeah, this is a great observation. I think I agree with you. I think in the posterior circulation, we have two types of diseases. The clots that we see primarily located in the top of the basilar, which we know they are going to be probably embolisms. And when we have the classic lesion, there are some exceptions, like maybe dissections, but the majority of mid-basilar or distal dominant vertebrals, we know are going to be ICAT. And I 100% agree with you. I think it's still the likelihood of ICAT in this population is a little bit higher than ours, but we are encountered those fairly frequently. And in this trial, that's what they need to kind of come up in the subgroup analysis, or they are now doing also a meta-analysis that they presented in the ISC, that they need to tell us how they treat those ICATs in the subgroup analysis different than the embolism, because my experience is the same as yours. If you don't treat those ICATs, they're going to reocclude. If you do thrombectomy alone, a large proportion of those are going to close. And whether we put a stent or angioplasty or just some chemical, it's not that clear. But in this patient population, I think that they didn't report it specifically in the paper, but I think they used the dual oral antiplatelets. I don't know the rates of IV that they use, but I think I agree. I think in the patient population, in the posterior circulation, if you just do mere thrombectomy without a definitive rescue therapy or rescue treatment with a stenting or at least angioplasty and antiplatelets, that is not going to do so well. We know from retrospective data, and we don't have a trial, and this trial is going to be extremely difficult to do, because how can we select patients for this, knowing ICAT only with a diagnostic imaging? We don't. It's quite different, quite difficult to know. Oh, this is going to be for sure ICAT. Then I can treat from the beginning and randomize. But I think in this patient, we know that when you have ICAT, at least from retrospective multicenter data, if you treat with a stenting, an angioplasty, and dual antiplatelets versus not treating that in the refractory thrombectomy, patients do better. I suspect in this patient population, probably they treated them aggressively. We have to see the subset, because it's 55% of the ones that got a stenting versus not a stenting, and see how they did. But I agree with you. I think thrombectomy alone is not enough. And in these cases, I think the use of antiplatelets, there's some evidence in ICAT, but I translate the evidence that I show you from the talk a few months ago from tandems. We know in tandems, putting an acute stent and doing antiplatelets might not be as risky as we thought initially. Then I still do at least IV 2B3 inhibitors in these patients in the acute phase, and then switch to orals afterwards.
Yeah, I mean, I think that's a real shift that a lot of people just haven't sort of caught on to yet, or have been afraid to adapt. The SAM feels so burned by that, and a little bit timid to be aggressive in treating these lesions. But that, if you can take those patients in that acute emergency and stent 55% of them and have a better outcome, that's a real shift in thinking. And I think you're exactly right that it applies to the tandem lesions also, and that we probably have not been aggressive enough with those in the past. At least I haven't been, and that's a shifting paradigm.
There is a couple of trials that Dr. McDougall that are coming up. The MOST trial, which is from the StrokeNet. They are going to really evaluate the combination of IVTP and endovascular with other agents, including DOACs and also 2B3 inhibitors. Then when we start to see that in those randomized trials, not only for the endovascular community, because I think the endovascular community might be more aggressive, since we have also the chance to do this when we are doing a stent-assisted coiling, or we have a thrombus in other, but for the for the vascular neurologists, when they start to see in randomized trials that the symptomatic and PH1, PH2 is not that significant when you give this additional antiplatelet or anticoagulants, I think maybe we'll start to have the shift in paradigm and we'll be able to use it more frequently.
Yeah, I am surprised too by the trials showing that the TNK 20% recanalization. I guess maybe I see such selected patients, but I'm not seeing. I don't feel like I'm seeing 20% recanalization rates out with TNK. It feels much lower than that. Maybe it's just in the middle of the night. Your counting is off, but that number seems high to me.
what we see a lot, and I don't know if it's your experience, is that because we get 86% of our patient population in Iowa is transferred from rural areas. What we see a lot is that the clot migrates, but you still have to deal with a problem, or then you have to deal with a DIVO or MIVO, not a DIVO because DIVO will be too aggressive, but a MIVO in the mid M2 or something like that from the original M1. We see that more and more frequently, but it doesn't fix completely the clot. As I said, the extend IA was great, promising, less than 4.5 hours, but timeless, presented 2 weeks ago, it was negative. Then it might not be as promising as we all thought.
Yeah. Well, again, thanks very much for that, Matthias. I'll turn it over to you.
Sure. Yeah, so I have a few questions. First one is, how can you define core? Since we know that, it's such a variable definition. There is even a review by Goyal, by Mayank Goyal, which, he even described the reversibility of core in CT after thrombectomy. The Japanese trial is mainly MRI based. The Chinese one in the large core is CT based, if I'm not wrong. The Tesla CT based. The Select 2 is CT and CTP.
Correct.
So we are playing with the definition of core, and there is no homogeneous.
Absolutely, and even among the trials, the definition of core is different. For Select 2 was more than 15 CTP, and Aspect 3 to 5. As Tesla is 2 to 5. Right. But I think definitely a core on the CT is probably more reliable than a core on the CTP. Okay, the CTP is an estimation, as you know, it's an estimation based on the curves when you inject the contrast, but the contrast, and also the CTP might be very limited within the early window, especially within the first 4.5 hours. It overestimates, and even MRI. Now there is data that there is some degree of reversibility. I think, and also the problem, the aspect is so heterogeneous, and there's so much inter-rater variability. In fact, they presented this, the results of Tesla is different based on, pragmatic design, which is the original design, versus core lab adjudication. And because the nomination of aspect is quite cumbersome. I think what I see in the future for interpretation, I think the CT scan, if you can see the hypodensity, might be a little bit more reliable than CTP. Obviously, MRI is probably the most reliable with the handicaps that you can have a reversibility, but it's not so. MRI right now is, unless you do this every day, 24/7, delays treatment. I still don't think that MRI for the majority of the world is not a feasible, pragmatic, thing to do. But in centers that are very used to it, it could do it. But I think CT might be the way to go. And what I think we are going to see very soon, and is that with AI, we're going to have a much better way to really identify this in a more reproducible, objective manner than aspect. Aspect, even among us, there's so much variability. When the AI algorithms, especially neuronal networking, improve, we're going to have automatic cores better defined than CTP. Until then, I think CT might be, and again, you were saying they have different imaging capabilities. They're putting together, or we are putting together a meta-analysis to identify also the different effects based on the imaging criteria and the imaging modality, which it might be different. But right now, I think it's almost like what you do with lay window, right? In lay window, do you need a CTP to do lay window? Or if you have an aspect of 7 in a patient that comes at 18 hours, do you feel comfortable treating? The majority of people would say yes now. And I think eventually we're going to go to simplify imaging with some probably help from AI to really simplify and make it objective and make it reproducible. That's what I think we're going to head it towards.
Okay. Another topic that I know that you're very interested in is tandem occlusions, and now we have the problem of large core trials. What do you think is going to happen with tandem large core?
Yeah, this is a very good question. in our registry, we have very little patients. We have a paper on review with only 50 large core, but in these trials, they include tandems, about select, there were 20% tandems, and between all of them, they might have about 150 patients. Then what I'm gonna try to do is hopefully just do a subgroup analysis to see, but my suspicion is in all these trials, they probably didn't give, they didn't put a stent. They probably did angioplasty and then went for it because of the fear. But we'll see. We'll see. I agree with you. And again, is what we are discussing. We are always very afraid of hemorrhage, but even in Select 2, the number of symptomatic hemorrhage was only 2 patients. And we are talking about 380 patients. And it might not be as prominent as we think. Even we have to see. We have to see. I think we need to analyze that. Right now, I'm still careful with tandems, large core. I still don't put a stent out of the blue until we have more data.
Okay. My last question is, what do you think is the current role of CTP now if we are selecting already patients with aspects of 3 and we show benefit?
I think this is a great question, Matthias. I think the role of CTP might be probably, it might still be with us because we need them for the MIBOS DIVOS. I feel that unless we get some AI multi-phase CTA, which, you know, the group from Calgary do that, but I think I still feel that for MIBO DIVOS selection, CTP is quite useful, especially the Tmax, because it gives you the hypoperfusion of the territory at risk. Then we can really complement and you know, because it's very difficult to pick a MIBO and DIVO only with CTA. And I think that the CTP with the large core trials, knowing that it's CT, probably you are correct. A CT for all, and then even we are simplifying with direct to angio, right? We don't even go to a CT before we go, and then do a Dyna CT in our angio suite because right now the new systems are pretty good. We can still not calculate aspects so well, but I'm sure with AI capabilities we'll be able to do that soon. But definitely a CTP might still have a role for the way I see it, MIBOS and DIVOS selection.
Okay, so those are my questions. Thank you so much, Dr.
No, my
Santiago.
pleasure.
It was an amazing talk and
Thank
very
you.
good as usual.
Thank you for having me. Always an honor and a pleasure to be with you. Thank you, guys.
Really appreciate you spending your time with us and enjoyed your talk. Thanks so much.
Anytime. Thank you.